Hi, I'm Hamza Bistani. I'm an associate professor of operations, information, and decisions at the Wharton School of the University of Pennsylvania. So today I'll be talking about the Wharton Healthcare Analytics Lab that we recently launched with my co-directors, Marissa King of Healthcare Management and Laura Zero from Analytics at Wharton. So the lab's goals are really about being a convening space for medical professionals, clinicians, data scientists, and machine learning experts so that we can tackle some of these challenges. Some of the problems that we've picked out to focus on are designing better algorithms for resource allocation, for addressing clinician burnout, as well as deploying better and innovative clinical trial designs. A big goal of our lab is to support clinical decision support systems in health systems broadly, including Penn Medicine. When we were thinking about this problem, part of it is just going to be using regular machine learning models. But we're also very excited about the potential of large language models in a couple different ways. So first of all, large language models can be trained on nursing notes or medical notes, which are largely untapped sources of information at the moment, and capture lots of useful information like socioeconomic factors, the patient's mental state, and so on, that aren't really captured by traditional clinical features, but do significantly affect health outcomes. So there are a lot of unintended consequences that can pop up with integrating machine learning and AI into healthcare. We really don't know what these large language models are doing under the hood. They're highly uninterpretable, and they also encode different biases that are undesirable. For example, they might not take into account women's symptoms the same way, take it as seriously as men's symptoms. And that's a serious issue that we need to address before we really let these tools become patient-facing. Another issue is equity, making sure that our data sets are well representing the population. So one of the things that we've been thinking about is how to set up effective guardrails for these algorithms, how to make sure we're collecting good quality human feedback to make sure that if we do run into certain biases that we're able to alleviate them or mitigate them going forward. I don't think we're at the point in time yet where these tools can really be patient-facing. So right now the focus has largely been, can they be clinician-facing with some supervision from the clinicians? So for example, you might draft some medical notes or a summary, which then a clinician would look over and edit, and that way there's a clear guardrail there. We're not letting these loose into the wild. And of course, any healthcare data set encodes biases because not all the patient subpopulations, those that face structural barriers, are underserved by the health system. And so we don't have high quality representative data on them. And so that's something that needs to be addressed. We've been thinking about doing that by leveraging proxy data. For example, cheaper but more quantitatively available data like Google search terms and so on. So I think a big challenge with machine learning is that the training data sets are very large. And so it's not always feasible to debias the training data itself. But what we're really interested in is the downstream decisions. So just to use our work in Sierra Leone as an example, where we're distributing essential medicines, in some locations, we have very low quality data on the demand of different medicines. And so if we try to train a machine learning model on this, it probably encodes those biases. It underserves locations that are already being underserved. But there are many ways to address this challenge, and one way we're thinking about is using these surrogate or proxy data sets. So for example, we might be able to use satellite data to infer population needs at a location, which is relatively divorced from the bias of the health system itself, where we're not realizing how much need is in a particular location. So by leveraging these auxiliary data sets, sometimes we can never perfectly debias the model, but at least the decisions that are actually coming out will be less biased. When talking about health systems and clinical decision support systems, a very large challenge is really bringing all the stakeholders together to make sure that whatever is being designed, when it's implemented, actually serves all parties. So for a lot of AI tools that have actually been FDA approved, many of them are still not being used broadly because they don't really fit into the clinician workflow effectively. And so it actually increases clinician workload, for example, by causing alarm fatigue, by having the alarm go off many, many times, or by not being cognizant of how the data is encoded at a particular health system and so on. And so a big challenge is really bringing all the stakeholders and convening them and ensuring that whatever we produce is actually something of value within a workflow. you.